Hello and welcome. Again, 7:30 in the morning. I am impressed with the turnout this morning. My name is Melody Herrera, and I'll be presenting, and this is my co-facilitator, Barbara Flores. First of all, we'd like to introduce our process, or our new abstract, in system automation for cancer surveillance. It's a data-driven tool for tracking head and neck cancer patients. Also, we want to introduce how we use the ABCs of ENT to track those patients. Of course, we have objectives. It's the what of the project. So I want to describe how the cancer care coordinator tracks head and neck cancer patients using an automated system, and with this automated system, using the corporate data warehouse. I also want to identify the ABCs approach that the cancer care coordinator uses to facilitate treatment and care of these patients. The purpose of this project. Being in this field, we know it's a great purpose. But for head and neck cancer, over 400,000 new cases of head and neck cancer per year worldwide are identified. The unfortunate thing with this is just under 50% of these cases reoccur within the first year post-treatment. So what are we doing about this? This is the question our team asked in Albuquerque, saying, how are we keeping track of these patients? And as most of you know, we queried Albuquerque, the VA, the corporate hospitals, the private hospitals. We queried some hospitals in Texas, in Arizona, even in Ohio. And what we identified is there's one of two areas how they track these patients. One, and you don't have to raise your hand, but I want to see your faces when I say this, we use a whiteboard. Anyone see the whiteboards in their offices? That's how we used to track cancer patients. The other is Excel spreadsheet. When Excel came about, we started using Excel spreadsheets and it became a manual pull. But to me, one of the more scary identifiers was there were providers and cancer care coordinators, that were using scheduling. They were using the VISTA package to track their cancer patients. And this is across the board. This wasn't one facility, this wasn't one clinic. A lot of providers were utilizing VISTA as their way to capture surveillance patients and to track them. We all know the problems we have with VISTA. I don't want to go with the numbers. I think 18% no-show cancellation rates. We don't want to go there. But we knew it was a problem. So we as a team wanted to identify a process in order to capture these patients. So what happened, we asked a question, and what was created was a robust automated program that we could track patients and throw them back in surveillance following the NCCN guidelines. We also wanted to prevent patient being lost to follow-up, and so far, once implemented, I think we've accomplished that. So do me a favor, I want the first 5 rows to raise your hands for me for a little bit. Okay, just keep them raised for a little bit. So in Albuquerque, we did some initial data. So we did a manual poll, and 31% of our patients were lost to follow-up. I want you to look around the room. That's a lot of patients not being tracked for follow-up, the front with their hands raised. So go ahead and put them down, thanks. You can keep them up the whole time. But I just wanted to show you how many people we actually lose to follow-up. And the unfortunate thing is Albuquerque was 10% better than other facilities. So what do we do about this? Again, we want to create a better program than what we had. So we enlisted the talents of a programmer by the name of Gregory Price. We asked the question first, can we do this? Gregory Price said, I could try. And guess what? We found the corporate data warehouse. As you guys know, the presentation was yesterday, and I know there was a lot of blank looks on everyone's face. What is that? Actually, we've been using it since February, so we knew exactly what it was in Albuquerque. So what we do is we query the corporate data warehouse to ensure that we get an accurate list daily. It updates every 24 hours. And you're asking, how do we do this? Well, we ask it a series of things that we want. We want to identify patients. We identify the patients by using ICD-9 codes. We identify the patients by using inpatient and outpatient discharge codes. We use VISTA problem list. And more importantly, we use SNOMED codes, which is a surgical pathology report codes. There are other programs out there that use different things, but we identified that SNOMED codes was one that they couldn't capture, and we were able to capture those SNOMED codes. So not only do we ask it that, so we get the patients named when we ask that question, but then we're able to customize what we want from those patients. And what do we want? Of course, we want the patient name, demographics, address, and phone numbers. But we asked it, when was your last or your most recent diagnosis? When was your last visit to ENT? We even were able to ask it, are you on recall? Can you give us a recall date? TSH levels, PET CT scans. We're able to ask it whatever we wanted it. So how does it work? If you're here at the presentation yesterday, you know everything we put into VISTA CPRS GUI goes to the corporate data warehouse. As soon as we enter it as clinicians, it goes directly to the warehouse. So what we ask it to do, we query it. We say, we go through our VISN 18 data warehouse and say, we want this data. So it goes to the corporate data warehouse, it pulls it out, updates it every 24 hours, and when the cancer care coordinator, Barbara, goes in the morning, she runs a report, 8 o'clock, and she gets a new list. It's updated in the last 24 hours, and any patient seen the day before is on this list. Well, within 24 hours, of course. So, actually, I'm missing an A on this list. The approach that we use is that we add patients. We use the ABC approach. So the first thing we do is we add the patients to the list. So when we customize this list and ask this for this list of patients, and Barbara pulls it in the morning, it gives us a list of patients that were pulled the night before. But it's not a validated list, so we do have to go through this list and identify the patients that belong to ENT. A good example, I'm going to go back to that slide. A good example of how we do that, oops, hold on a second. A good example of why we do that is, say we get a name on our list and we look it up and we identify this patient was seen last week or yesterday in his primary care office, but he has no history with the Albuquerque VA or any VA. So we do a little history. We find out that this guy's always had private insurance. He's always seen on the outside, but he lost his job and had to be, had to come to the Albuquerque VA to be seen. He went to his primary care provider, and he told his primary care provider, yeah, I had a tongue lesion surgery last year. It's all good, though. I feel better now. So the primary care provider could put in a consult at ENT, but if he doesn't, that's okay, because we will pick up that patient on our list due to the problem list. So we call the primary care provider when he comes up on our list and says, hey, give this guy a consult at ENT so we could see him and put him back on surveillance. The next thing we do, we browse the list. What we're browsing for, like I said, we customize it to ask for specific things, PET CTs, TSH levels. So a good example of this, we see this patient in February. He has a PET CT in February as well. But his follow-up visit isn't until October. But when he goes to his PET CT, we identify that he has a new malignant neoplasm. So do you think we should wait till October to bring him back in? No, we need to bring him back right away. So we get with the provider, we set up a special appointment and bring him in right away to identify the patient's new needs. One of the most important things we do is we check the list. We check the list for patient appointments. Every patient that's in surveillance, especially following NCCN guidelines, we track them. We own them for 5 to 7 years, depending on the cancer diagnosis. So what do we do with that? Well, if you notice on this list, right here, there's a C. What does that mean? That means the clinic was canceled. How many times have you guys had a clinic canceled without the patient being rescheduled? It happens all the time. Then you have an NS. Everyone knows what that is for because that's our no-show. No-show without reappointment. And then we have a PC. These are the patients we lose. Everyone says they have a robust program, but how can they track patients who cancel their appointment prior to the appointment date? To my knowledge, there's not a way to track that yet. but we can through this process. And then what we do is we call these patients and recapture them and put them back into surveillance. When they're in this column, that means they have a scheduled appointment already, so we don't have to worry about them unless something else happens that pops up. So everyone love recall? Let me see your hands. All right. If you're in surveillance, you know recall is, to me, is kind of hard to deal with. So what we did in Albuquerque, we were able to pull the recall patients on this custom list. So you could set the parameters, but for us, 21 days before the appointment, the patient's name highlights, and we know it's time to see that patient again. So not only is it on the list, it actually highlights for us so we can recapture that patient. So the question is, does it work? Well, after we initiated it, we feel that we've captured 100% of patients, 17 to be exact, from February to July. And quite honestly, I can't say we would have captured that using a manual pull or doing a little manual Excel spreadsheet. So by doing this data worksheet, we're able to capture these patients. And we can put them back into treatment or surveillance following NCCN guidelines. So what are the benefits of this program? Well, initially it's a lot of work because you have to create it. But after that, I would say not cruise control, but it's a little easier. You're able to pull these patients. It's less work intensive. It improves workflow, improves patient safety, of course. That's why we're all here. It works so well, we're actually expanding to the other 7 top cancers in the VA, from lung, kidney, bladder, prostate, breast, melanoma, and colorectal. So of course, cancer is complex. Surveillance is hard. We didn't have a good process as we identified. And personally, I know, and we know as a team, because we went to go look at other facilities, they really don't have a good process either. So we created this new data-driven process that works for us. And I just want to ask everyone out there this one question. What are you guys doing to track your patients? A special thank you goes out to Barbara. Barbara is the person who asked the question, can I do this? Gregory Price, the program data analyst, is the guy that said, let's try. Myself, I supervise the project. And a special thanks goes out to Dr. Glenn Murata. He was our mentor for disease management. And of course, we can't do it alone. We had a great surgical cancer committee to support us all the way. Questions?